Good evening, everyone. We're going to talk tonight about obsessive compulsive disorder when intrusive thoughts become a problem. So just to start by, here we are, introducing ourselves. My name is Lomax. I'm a clinical psychologist and program director of the clinical psychology program at Newcastle University.
And I'm Holland. I'm a cognitive behavioural psychotherapist. I work within the School of Psychology. Newcastle University has a specialist psychology clinic where we're able to actually offer full courses of treatment to our undergrad and postgrad students. And in addition, I also lead on the postgrad qualifications in cognitive behavioural therapy. So I lead on the depression module in the second year that our students attend.
And this is just a photo of our team at the clinic at the university. So that's just to introduce ourselves to you and just to let you know what we're going to be talking about today. So we're going to be talking about what are intrusive thoughts, what should we do with them when we get them, what happens when intrusive thoughts become a problem, how intrusive thoughts relate to OCD, which is going to be the theme of the talk, and what is OCD, as in what is it? A lot of you all know it is washing or cleaning and tidiness, but it's a lot more than that, so we'll talk a little bit about that. And then how can we treat it using psychological therapy or talking therapies?
So they can be in relation to the circumstances that you find yourself in at the time. So an example of that might be, you know, if I'm walking over a bridge talking on my mobile phone, all of a sudden I just get this thought of throwing my phone over the bridge into the water. It came into my head unexpectedly. I wasn't planning for it to happen, and sometimes it might catch me off guard, but that's the kind of the nature of the thoughts that we're talking about here. On the other hand, intrusive thoughts can also be completely random. So they don't necessarily have to be related to the circumstances that you find yourself in. You could be happily sat at home one day and then just completely experience a random, unexpected thought that you just weren't planning on having. An example of that might be, you know, you're doing your homework one day and all of a sudden you get a thought of something awful happening to a family member. So I think regardless of whether they are kind of expected or not, what we want to try and say here is that they are normal. Everybody experiences intrusive thoughts from time to time. They are definitely a normal part of the human experience. And we can think of intrusive thoughts almost as a side effect of the way that our brains are designed to function. So our brains are incredibly complicated organs. They're capable of producing and processing vast amounts of information very quickly. And sometimes intrusive thoughts can occur almost just as a side effect of the way that our brains are designed. So again, it's thinking about the fact that a lot of the time they can be unpleasant or weird if we're not expecting them to happen. But intrusive thoughts can also be neutral, or they could be quite pleasant or enjoyable. They can be an ordinary part of everyday life. If you sat in class one day and suddenly have the thought of, where did I leave my charger? What if my phone dies? What if I fail this exam that's coming up? These are the kind of thoughts that we're talking about here. You can experience them as doubts or worries as well. And again, they can be quite enjoyable. So the other side of the coin is thinking a little bit about intrusive thoughts as something that can inspire creativity. You know, getting a random thought or idea that you weren't planning on having can be a really good way of being creative, and it can be used in helpful ways sometimes. So again, we're not just talking about upsetting thoughts. An intrusive thought is any kind of, and what we know is from our research is essentially just how normal intrusive thoughts are. So this following information is taken from a study that kind of interviewed a sample, quite a big sample of students. And what it found was that 99% regularly reported having intrusive thoughts. I don't mean once in a blue moon, I mean regularly, you know, so sometimes every day, sometimes several times a week. But out of the content of these thoughts, the following themes were identified as normal intrusive thoughts that people could experience. And we want you to keep in mind here that this population was an ordinary student population. It wasn't a sample of anybody with mental health difficulties. This is just a normal part of the human experience that we're talking about. But students identified having the following kind of intrusions. So hitting animals or people with a car, hurting someone you care about, or hurting a complete stranger, getting contamination or a disease from a door or a public object, accidentally leaving the oven on or the stove on and causing a fire, leaving the taps on and flooding the bathroom, sometimes swearing really inappropriately and unexpectedly in public, sometimes jumping off a bridge or jumping off a building if you're stood on a high floor, grabbing money that you can see somebody holding, insulting strangers. I mean, the list goes on. I'll just make them appear on your screen here. But essentially, the range of topics about intrusions can relate to anything and everything. And what we thought might be quite interesting to just kind of start things off is to do a little bit of a poll. So this is where I think we need, I think it was Felicity or Fiona, was it, who made this poll available, but we thought it would be interesting to just give you guys about a minute and think about whether you can identify with the following intrusive thoughts. So who among us has had thoughts from the following categories? It could be something horrible happening to a family member, a pet or a friend, shouting something rude out randomly, or randomly hitting or attacking somebody. It might be worrying that you've left something switched on that could cause a fire, or worrying about germs and dirt and contamination. And it may be all of the above or more than 3 of the above. So we thought it would be interesting to just make this poll available now. Within 30 seconds, I think over 200 people just said that, just raised their hands. So hopefully these are thoughts that aren't unusual or uncommon, and it's something that we all experience from time to time. So if we think a little bit about the way that we respond to intrusive thoughts, this is the kind of area that we're more interested in as clinicians, because given what we're saying about how normal and how common intrusive thoughts are, they only ever really become a problem when we respond to them in a way that can sometimes unintentionally make them worse or make them more problematic for us. So essentially, if you get an intrusive thought and you don't think too much about it, even if it's quite a shocking or unpleasant thought, if you just let it go as an event in your mind, it doesn't really cause any more anxiety or drama than that. It's just kind of our minds move on to other things. But for a minority of people who get intrusive thoughts, they might start to worry about them. They might start to pay them too much attention. And they might start to worry about what it means that I had this thought that I wasn't expecting to happen. And sometimes people can begin to attempt to suppress or push their thoughts out of their mind. What we do know is that if you try to suppress a thought that you're having, it'll actually have the opposite effect. It'll make you experience the thought more frequently rather than removing it from your mind. And I think for that reason, we thought it would be interesting to just, where you're sitting now, try a little quick experiment. So we're going to suggest that for the next 30 seconds, we would like you not to think about a polar bear ice skating. Try your very hardest to not have that thought. And if the image of that polar bear pops into your mind, just push it away. If it comes back, push it away again. I mean, straight away, I'm thinking about it.
Think about it being on skates and how it can move on.
Yeah. And I guess, you know, what's happening when we try to suppress these thoughts is something called the rebound effect. So it's like we were saying before, trying not to think something is paradoxical. So in order to decide not to think something, you're already thinking about what you're trying to not think about. And actually, if we think about how this might apply for intrusive thoughts, if we have a thought that's caught us off guard that might have scared us a little bit, that we might be worried about, that we then decide not to think about, we try and react by pushing that thought away, it's going to cause the thought to bounce back into our mind even more, which would make us even more worried about it and try and push it away again, and so on and so forth. So we wanted to give a little bit of an example as to how ordinary intrusive thoughts that don't have to mean anything, the way we react to them can sometimes cause them to become bigger problems than they need to be.
I just want to go a little bit about some myths that there might be about, and this is my lovely picture of a gorgon.
Medusa, right?
Medusa, yeah. So we don't often talk about thoughts themselves. We don't sort of think about thoughts as an event or a thing that we're having. And so there are lots of myths that we have in our minds about thoughts that we probably don't discuss with people or challenge with people. And these are myths that I've kind of gathered over the years of mainly working with clinicians, actually, as doctors, therapists, and whenever we do this training, lots of people come forward with surprise, don't they, about regularly people would say in training sessions, do you mean everybody has these kind of thoughts? And often they'll disclose horrible thoughts they've never told people, and they've always just worried it's been just them. And so these are the myths that we've kind of gathered over the years, that the myth might be that a person wants to act on these thoughts. If you have these kind of thoughts, like hitting somebody or doing something horrible, that they actually want to act on it. And if they find these thoughts upsetting or distressing, it's always that the opposite is true, but usually people work hard to fight them because they're horrible, because they might result in the family member being hurt or something horrible happening. But because they're working hard to fight these horrible thoughts, their thoughts, as Stephen explained, become more persistent because you're paying so much attention to them.
We're much more likely to act on thoughts that don't horrify us. So the fact that these thoughts can often be quite scary and unpleasant, it means that we're less likely to act on them in real life.
Just occurred to me that Gorgon's a little bit like a horrible thought, isn't it? So another myth is that all thoughts are really important and worth examining. We should look at all thoughts, particularly nasty or horrible ones. And this is another kind of myth, really, that actually thoughts don't always mean anything. They can be silly or horrible or unpleasant, even if they make you feel scared or bad or sad. They don't have to mean anything. And sometimes people get a bit muddled that having the feelings about thoughts means they're important and that they have to examine them and pick them apart and make sure that you know what they mean. But actually, not all thoughts are worth examining. Some more myth busting. This is quite a common one, particularly in OCD, which is that having a thought is as bad as doing it. So if you are having a thought about something horrible happening to somebody you love, or you doing something bad to them, that's as bad as you doing it. And it's a little bit superstitious, but it's really, don't confuse thoughts with actions. Thoughts and beliefs, things that we believe, are not facts. You know, somebody might, for instance, be very religious and then change their beliefs and live differently. So the whole belief system might change. So thoughts and beliefs are flexible and can alter and change.
And thoughts are not actions. So if you, I mean, one way of thinking about this is if having a thought was as bad as actually doing the action, could you imagine what our prisons would look like? You know, they'd be full of people who had a thought of punching somebody or had a thought of killing somebody they didn't like. So there's a big difference between having an unpleasant thought and the decision to actually act on that thought and follow through with the behavior.
Another one is that it's, again, this is a little bit superstitious or magical, really, but that having thoughts about something bad happening increases the chance of it happening. So if you're, it's a quite common one we might ask people to do is write down something bad happening. This is when we're training therapists, something bad happening to a family member. And therapists really struggle, everybody struggles to do that. They don't want to write it down. They don't want to, just in case it happens, or just in case, even though they know it's just a thought and just write it down doesn't make it happen. We're all a bit superstitious about things like that. But if you think about it, if it was writing something good about it down, everybody would do it. And if you think that thoughts are just thoughts, for instance, I said to you, right, if you think as hard as you can about winning the lottery on Friday, about going and buying that ticket, do you think it's more likely to happen if you thought about it every day as hard as you can? So we should treat horrible thoughts the same way as we would positive thoughts.
Clinically, we'd refer to this type of belief as magical thinking. It's often the belief that, you know, if I think this enough, it'll somehow cause it to happen. And if you have a horrible thought and you believe that thinking it could cause it to somehow materialize, it kind of explains how upsetting these thoughts can make us if we start to apply some unhelpful meanings or importance to them.
When do these negative intrusive thoughts become a problem? So usually the positive or neutral ones we don't really worry about, but when they're unpleasant or scary, we're more likely to notice or worry about them. And then that in itself becomes a problem when we start worrying about them, start dreading having them, or start getting anxious about having them. If they make these thoughts feel scarier, they make them last longer because we're kind of examining them and thinking what they mean and what they, so really almost picturing them happening, so they get quite real to us. If we start really imagining something horrible like happening to a family member, or you getting very ill or something, people start picturing it, imagining it, so it kind of takes hold of people a bit. And as Stephen's sort of exercise showed you, it increases the chance of thoughts returning again. So you might more like to keep having it if you're worrying about the thoughts and having the thoughts.
So one way of thinking about it is, you know, the intrusive thought itself doesn't have to be a problem, but the thoughts the person has about their intrusive thought might be a problem.
Yeah, oh, that's mine.
That's
the animation. Okay, so these are really common needs that we all feel about these intrusive thoughts. So, you know, if I have when my daughters were young, I might have an intrusive thought that I might accidentally hurt them or hurt, that would pop into my mind. And it's sort of, what does it mean that I've got this thought? What does it say about me as a mother, as a person? Does it mean I'm a bad person to have these kind of thoughts? And actually, could thinking this cause me to lose control actually do it? If I started worrying about that, so I might start doing all kinds of things to make sure that I made everything safe around me. So these kind of thoughts are very common to think. And then this magical thinking, thinking about hurting something like my daughter actually cause it to happen somehow.
Yeah.
And then the next sort of stage of this really is, if I have thought this, I must make 100% sure it doesn't happen, like making sure somebody's with me at all times with her, or...
I mean, an example of that, I think quite a common one is, you know, if somebody's leaving the bathroom and they suddenly get an intrusive thought that I've spilt water on the floor, and what if somebody comes in and slips and injures themselves? That would be my fault. Now that I've thought it, I've got to go and make sure the floor's dry, and I'm going and checking the floor. And so all of these are examples of thoughts that we might have about our intrusions. The intrusions on their own are just thoughts. They don't have to be anything more important than that. But it's when we get into starting to worry and putting these kind of beliefs on top of the intrusion, that's when the intrusions can be much scarier for us. So here's a little worked example of what we mean by that. So I want you guys to imagine that this is you for a second. Imagine you're walking down the road and you pass a stranger. You're walking on the pavement, but it's by quite a busy road. There's lots of cars coming by quite fast. And all of a sudden you have the intrusive thought that I could just push that person in front of that car. You weren't expecting that thought to happen. It caught you off guard, but all of a sudden you've got this thought in your head that I could just push that person in front of the speeding bus that's approaching me. But let's say the way that you react to that thought is with the following meaning. Let's say you genuinely believe that, oh, that was a horrible thought, but it was just a thought. I know that I'd never do that. How will the intrusion make you feel? Well, it's still not a nice thought. It might make you feel a little bit of anxiety for a moment, but you're not really going to dwell on it. You're not really going to have any lasting distress from that event in your mind that happened unexpectedly. And you're probably going to quite quickly move on with your day and move on to whatever the next thing was that you had. On the other hand, same scenario, you pass that stranger, you get that thought that I could just push them in front of the car. But let's say you give it a bit more meaning. Let's say you put a bit more importance on it. And instead of thinking it was just a thought, let's say you really start to worry, oh God, I must be really dangerous if I'm having a thought like this. What if I really could hurt that person? What if this thought means that I'm actually a violent psychopath? And what if I'm really at risk of just losing control and this thought's going to make me become violent? Well, all of a sudden, that same intrusive thought is much, much scarier. And, you know, the same intrusion is leaving the person in a place of feeling really scared, really worried, really fearful that they have to now do something to try to block the thought or go to great lengths to make sure that it doesn't happen. So this is a little example of how what might just be quite a fleeting intrusive thought can actually grow into something much more long-lasting and painful and distressing. And it's all based on the thoughts we have about the intrusion, not the actual intrusion itself. And we'll get into this in a few minutes, but when we offer treatment to these kind of persistent problems, we don't actually attempt to stop intrusive thoughts from happening because we can't. In therapy, what we would do is we would try and help the person change the meaning they're giving their thoughts rather than the thoughts themselves. And again, paradoxically, if a person is able to have these thoughts and not really be too bothered by their presence, then the thoughts tend to occur less often. So again, if we feel like we can't ignore these thoughts, the majority of people who get intrusive thoughts will just dismiss them or ignore them or move on from them quickly. But for a small group of people who get these intrusive thoughts, their reaction to the thoughts, the meaning they place on them and how upsetting that makes them feel, it can cause them to almost get into patterns of behavior that cause a vicious cycle where their reaction to the thought is actually increasing the likelihood of the thought returning. So they then react to it again, which increases the likelihood that it returns. And it can get into this really horrible back and forth, this vicious cycle. And it's an example of how ordinary intrusive thoughts can grow into something much more persistent. And this really is the mechanism that people can go on to develop more persistent anxiety problems like obsessive compulsive disorder, or OCD for short. OCD is a common anxiety disorder, but it's made up of normal human experiences. What's unique about somebody with OCD is the reaction they have to their normal intrusive thoughts. That's what we're really trying to get at here. So because the person worries too much about the meaning of their thoughts, it can lead to problems like OCD.
We're going to just move on to talk about OCD in a little bit more detail. So just a little bit of sort of technical detail really about OCD. It's a psychological disorder. It's typically diagnosed by a clinical psychologist or a psychiatrist. It's a common mental health disorder, and 1 to 2% of the population suffer from it. And obviously the misconception is that it's about cleaning and tidiness. And actually, it's good to be a little bit OCD because actually then you have a lovely clean house.
We really struggle with the phrase, I'm a bit OCD. It's something that people tend to say quite colloquially, but we're talking about much bigger life-altering problems than I'm a bit OCD.
And so the technical way that we would diagnose it is that it's where someone has intrusive thoughts, we were talking about, which could also be images or impulses, which we are called obsessions, and they do things, they do behaviors or mental actions to try and get rid of the feelings generated by the obsessions. So that's the obsessive and compulsive parts of the diagnosis. And these compulsions are done to get rid of this anxiety or distress caused by these horrible thoughts. And they do provide short-term relief, but in the long term, we know that they keep the problem going because they don't challenge the meaning. So nearly always the person will try to resist doing their compulsions or have tried in the past to resist. But it will be incredibly hard for them.
I mean, we're talking about a real difficulty resisting. Like, imagine the worst itch you've ever experienced and trying not to scratch it. You know, people with OCD will really have this strong pull towards these compulsive rituals or behaviors or patterns. And it can be really distressing to try to resist that temptation to act in that way.
An example would be that somebody has intrusive thoughts about catching an illness and hurting the family. So an intrusive thought might repeatedly be that I'm going to pick something up if I go and touch these doorknobs and the toilet seats, and that I'll catch something horrible and then give it to my family. And imagine how awful that would be to be responsible for giving a disease or an illness. And it doesn't have to be logical. It doesn't have to be the person might logically know they can't, but the feeling is so uncomfortable and distressing that it feels real. And so what do they do to get rid of these obsessions? They compulsively might start washing to decontaminate and clean. And that might be the cleaning their hands or their bodies or their clothes or not touching their shoes.
But we're not talking about an ordinary hand wash.
No.
Imagine being hyper vigilant to the way that you need to wash your hands, having a meticulous method in mind, or I'm counting as I'm doing it. And if I mess up, I've got to start over and I've got to be 100% sure that I don't have this contaminant on my hands. It can take hours of somebody's day, this type of compulsion. And
we know that we call OCD a bully. So we're working with children. We would kind of use that as a way to externalize the problem. And it's really good with adults as well, actually, because OCD is a bully. It wants you to do more. So if you start off by doing a little bit of hand washing, for instance, in this example, it might actually say, well, actually, the OCD might be, that's not enough now. I need you to do a bit more, actually. Change your shoes every time you go out. Don't wash your shoes when you come in. It will just demand more and more if you give into it. And as we've said, they usually try and ignore or suppress these intrusive thoughts. But to get a diagnosis clinically, the person must be significantly distressed by the thoughts. Really, they're usually really abhorrent to them and unpleasant and distressing, and or they get in the way of everyday life. So, for instance, with this example, it might be that they struggle to leave the house before they've washed to the point that OCD is happy, or ask other people to get involved in helping them wash. They might ask them to check the washing. And so the impact of OCD, it's a particularly severe and disabling problem. And of all the mental health, of all the anxiety problems, it has the longest lag between onset and people coming to a clinician for treatment. It's 15 years on average.
For a long time.
Yeah, hiding it because it's a very sort of shaming sort of problem. So imagine 15 years of this on average, how much worse it can get with people hiding it and doing what the OCD is telling them to do. And they can have their lives completely ruled by their obsessions and compulsion. Hours can be spent doing what they need, what the OCD is telling them to do, to either stop or prevent their intrusions. And it's always about them trying to stop the bad thing happening that the OCD is telling them might happen. And we're talking about a real disabling problem here. You know, we're talking about the kind of interference where the person is unable to go to work or perform their job or
maintain their house or keep up with friends because they're so preoccupied with their intrusions and attempting to suppress them or stop them from happening. It really does kind of derail and compromise ordinary human experience.
Most extreme, but it's also obviously there's obviously milder versions, aren't there, of people? That's the kind of extreme version of it. But there's also people who have it and struggle with it but can get by. But it's a kind of it's a continuous spectrum, isn't it? But it may prevent sufferers from achieving their goals. So when we see adults, it might be that they haven't done the things that they want to do, like traveling or getting married, having a baby, achieving their career goals. It can really get in the way of people's lives. And as I mentioned, it can impact on other people around them. So, for instance, for the cleaning one, for instance, it's very common that people would ask their family, their parents or partners to help them with cleaning, or to check, is it clean enough? Whatever the OCD flavour is, they can ask other people to help them or to get reassurance from them that they spread. It can spread. Okay, so final bit just about the OCD is, we've mentioned that this is a myth, it's a little hand washing or checking light switches. And another myth is that OCD sufferers love cleaning. Well, hopefully you know now that they don't love it, but they feel compelled to for reasons usually about protecting people or themselves.
It's more than just preference.
Yeah. And these are diagnostically the 5 types of OCD that we see. We call them flavours, is the other phrase for them. Checking is a very common type where people need to check things like locks, taps, light switches, electricity plugs and things at home. Contamination we've talked about. Symmetry and ordering is another type of OCD where people need it just right, feeling very uncomfortable unless things are either symmetrical or very ordered. A very common one that we see probably the most is one about ruminations, where people have fears or worries that they're going to do something horrible or hurtful or unpleasant. And that's one that they feel they struggle to tell their GP about or tell mental health professionals about, because
it's very shaming.
It's very shaming. Sometimes they're quite horrible, the sort of thoughts they're having. So they might do things like mentally get rid of the thoughts, push them away, have other positive thoughts. And then hoarding is the last one.
But having talked a little bit about OCD, we also wanted to kind of end by sharing how we would treat it. And one of the best evidence-based ways of treating OCD, often in combination with certain medication, is through a talking therapy called cognitive behavioral therapy, or CBT for short. And this is the type of therapy that we're both trained in as clinicians, and it has a very good track record of helping people overcome these vicious cycles and these patterns that we've been talking about so far this evening. So I wanted to just briefly play a quick video.
Cognitive behavioral therapy, or CBT, encompasses a range of talking therapies based on the idea that thoughts, feelings, what we do, and how our bodies feel are all connected. If we change one of these, we can alter all the others. When we're low or upset, we often fall into patterns of thinking and responding which can worsen how we feel. CBT works to help us notice and change problematic thinking styles or behaviour patterns so we can feel better. CBT works for lots of different people and problems and is widely recommended by national treatment guidelines across the UK, EU and North America. For more information and to find an accredited therapist in your area, go to the website of the British Association for Behavioural and Cognitive Psychotherapies, babcp.com.
So hopefully that gives a little bit of an idea as to how CBT works. What it isn't is something that is done to or performed on the client or the patient. It's not like a person shows up once a week to a room and the therapist does something and they leave feeling better. It's much more a way of working together collaboratively as a team. It's essentially the therapist and the patient working out together what's keeping a problem going. The therapist knows more about CBT, but the patient knows more about their own life and their own experience. And it's about two people sharing what they know to try to make sense of what's keeping that person stuck. And through therapy, the patient can learn that their thoughts are not as dangerous as they believe in OCD. We would be inviting people to really try and test out their thoughts and finding out whether or not what they think will happen will happen. And we're going to get more into this in just a minute or so. But essentially, we're guiding people with questions and we're helping them to make decisions. We're not giving them instructions or trying to do things to them in CBT. But by understanding the connections between the way they think, how they feel, and what they do, CBT can help people to break out of patterns like OCD. And we just kind of wanted to give a quick example of what this might look like. But the kind of vicious cycle that we'd be interested in with OCD, if you imagine again, a situation where you're faced with an important exam at the end of term, and all of a sudden you have the thought, I'm going to fail this exam, I'm never going to get the grades that I need. That's certainly a thought that I've had before. And that thought is likely going to cause certain feelings. Thinking that you're going to fail is probably going to make you feel nervous or anxious or scared. But feeling anxious and scared will have a knock-on effect on what you feel like doing. Maybe I stop studying and put off revision. Maybe I end up spending my time worrying instead of revising, and I end up with less time to actually do the work. And that behavior can reinforce the thought that I'm about to fail. So again, the exam's not the problem, but the way that we respond to the situation of the exam might be a problem. And in CBT, we really help people to try to spot these connections and reflect and notice them in their own lives, with a view to learning how to respond differently to their thoughts or their behavior that's perpetuating the problem. Now, what this might look like for OCD, if you imagine this example, somebody having to leave the house and all of a sudden they get an intrusive thought that they've left their hair straighteners on or they've left the iron on. And rather than that thought being dismissed as just a thought, instead, they give it this meaning that this is more than just a thought, this is really happening, and it's my responsibility to make sure my house isn't going to burn down. That meaning plus that intrusion is going to make them feel really scared. Feeling really scared is going to make them go and check, stare at the straighteners, touch to make sure that they're switched off. And that behavior, as Claire was saying before, might be helpful in the short term of giving some relief, but in the long term, it's going to encourage the intrusive thought to rebound back again, and the person's going to find themselves trapped in these cycles. But there's a particular type of intervention we'd use within CBT for OCD, and I think you were going to talk a little bit about that, Claire, weren't you?
Yes, it's a quick whistle-stop tour, and we've only got a few minutes left. Obviously, we've got some of your questions. So just to give you the real key points about how we treat OCD, because it's really successfully treated using talking therapy. So this is just a quick summary that we use the cognitive theory, the evidence-based theory for this, is that unacceptable intrusions are normal. When they've occurred, the person with OCD overreacts to them. And they respond by trying too hard, which might be to get rid of the thought, to prevent harm, to be absolutely sure, to be clean. And so in the short term, they feel better. But as time goes by, their solution, which is to do a compulsion or a behavior, becomes the problem. And so I've got another animation there. So let's think about all other anxieties and worries. How do you get better from something you're scared of? And I'm sure we all have one of those or more of them you might all recognize as something you might be scared of. They're most common fears and phobias we've got. So the way we treat this and some of you might be, as we talked last year on phobias, that kind of went into more detail, but the OCD is a type of anxiety disorder, so it uses the same techniques, which is a part of CBT called exposure therapy, which we try and work out with you the elements that you're scared of related to your fear or phobia. So it might be, say, with spiders, it might be the fact that they're jumpy or that they've got horrible hairy legs, but it might not be, I might not be scared of the same thing you're scared of about it. So we try and work that out. And then you probably all know about facing your fear. We try and help you to work out all the sort of, if it was spider phobia, for instance, looking at a little picture of a spider in a cartoon might be a lot less scary than looking at a tarantula or having a tarantula on your hand. So we work out all the different parts of your fear, and we kind of get you to tolerate having that spider, looking at the spider, touching a spider until you've got used to it. And we have to we ask you to stay, as if you're a patient, in that anxiety situation until you get used to it.
If you spend enough time next to the thing you're scared of, you'll stop feeling less scared just naturally on its own. It's just the way that our brains work with emotions. If we feel them for long enough, they gradually decay. They have a lifespan. Sometimes a way of thinking about it is, if you imagine your favorite stand-up comedian or your favorite comedy show on the telly, and let's say you watched a 5-minute clip that at first was hilarious. If you watch that same clip over and over and over again, it would quickly start to get less funny. And it's not that you'd be trying to suppress the funniness, it's just that naturally that feeling of funny, of humor, would just decay on its own. And it's the same with anxiety. Often we escape or avoid the anxiety as a way of getting rid of it quickly, but if we stay in the presence of the thing we're scared of long enough, sooner or later our fear will come down.
This is the dreaded facing fear, isn't it? Okay, so, and if we stay in the anxiety situation and to the point where we get used to it, which is usually about 20 minutes, that's all our body can really cope with. And then you'll have had it with exams, that you've been very anxious for it. And then your anxiety you just collapse a bit and you go home, you're tired out because you've had such an adrenaline spike. But if we do it and test ourselves out in the scary situation, we might find out that it hasn't been as bad as we thought, or even that it was as bad as we thought, but we survived it.
We managed it better than we anticipated.
And we feel a bit more confident next time that we feel better this time than last time we did this talk with 500 people. So we've kind of habituated to it. So it's exactly the same in OCD, but in OCD, I hope this makes sense now, that the anxiety, the phobic sort of stimulus, we call it, is the intrusive negative thoughts. So the scary thought, I'm going to catch a disease and give it to my family, might be the intrusive thought. And we might even get people to say it over and over again until I get bored of it.
Yeah. So the aim of the exposure is to spend time with the thought that they're scared of and repeat it and hold it in mind until that thought feels less scary. It's not that they're scared of a house on fire. Anybody would be scared in that situation. With OCD, they'd be scared of the thought that the house is on fire. And ideally, we want them to experience their intrusions as neutrally as any other thought. So through exposure, through repeating a thought over and over again, without carrying out that compulsive response, the thought that, my friend's going to have a horrible accident this afternoon can be about as benign as, I wonder what I'll have for tea later, or I wonder what's on telly tonight.
So it's about exposing thoughts and help them stop their behaviors or compulsions to see that nothing bad happens. So the aim of the therapy is to help people experience less anxiety, that has less meaning importance to them, and it's real and it's going to happen because it's just a thought I'm having, and as you say, it's just another thought. And OCD UK, they give badges away, and that is just literally it's just a thought.
So imagine, the exposure to the thought as I'm leaving the house, I get the intrusive thought that I've left the front door unlocked and there's going to be a burglary. Rather than going back and checking, we'd be encouraging that person to keep walking away from their house and carrying on with their day, but repeating the thought that my front door might be open, my front door might be open, my front door might be open. Sooner or later, that thought is not going to evoke the same level of anxiety as it does when it spurs a check. And it's that prolonged exposure to thoughts that really helps people out of their OCD.
And the good news is that people can recover from OCD, and it looks different from each person. Everyone has slightly different treatment, but usually it's about helping people experience intrusive thought without worrying about it, without doing a behavior to get rid of it. And it's really, hopefully this will explain, the key is how they respond to the normal intrusive thought and help them get back on with their lives. So that was a real whistle-stop tour.
There's some resources we thought might be helpful.
If any of you have got any worries about this. And so hopefully this has been helpful to you to understand what intrusive thoughts are, but also, I guess, if any of you are interested in mental health and interested in what we're talking about, then psychology, clinical psychology is a great career and a great option in mental health, and you can do this kind of talking therapy and really change people's lives and improve people's lives. So
it's really rewarding to help somebody out.
Very happy to take questions.
Just in the nick of time, but thank you very much for listening.
So a few people asked, so I'll start with this one, is OCD hereditary?
That's a very good question.
I think we had a similar question last year.
We did.
Yeah.
There's two answers to that in a way, that it's not hereditary in that there is a hereditary component to it. As all these things, they're kind of multifaceted. So no, it's not hereditary. But what we do know is that sometimes parents can model it for children. They can see their parents doing things and overly reacting to perceived danger like contamination, and kind of teach their child to react in certain ways to the OCD.
Yes, that classic nature versus nurture debate, isn't it? And for all that there may be certain genetics that might create a vulnerability to a person feeling stronger anxiety, it's very much the relationship the person learns with their anxiety, that it has modeled the skills they learn growing up, we would probably advocate more for nurture as a component of what could cause this kind of problem than a genetic predisposition as such.
And another one that someone's asked is, can OCD be cured, or is it a lifelong condition?
Well, I mean, it depends what you mean by cure. We've certainly helped many people achieve recovery in terms of their symptoms just not happening. And we would say that somebody has achieved recovery not when their intrusive thoughts have stopped, because those thoughts are normal, but it's when they're able to get the same intrusive thought and experience it as neutrally as any other thought, and to genuinely believe that this is just a thought that I'm having. I have no urge to go and respond to this thought as if it's anything more. So if you're talking about cure in sense of the thought stopping, I think that's impossible. But if curing means not having your life ruled by urges to respond to these thoughts, then that's certainly achievable through the therapy that we're trained in.
Another question that someone's asked is, do you feel that the misconception OCD is just about being clean is harmful, or do you think it's got the potential to actually spread awareness for OCD?
That's a great question. Certainly the OCD charities find it's quite dismissive of the problem, and that it makes people take it less seriously. But on the other hand, I do take the point that having some more awareness of it is always a good thing. But it probably is a little bit, it probably doesn't really capture. So when somebody has sort of horrible thoughts about hurting children, hurting people, that it's not the sort of expected type, because people are thinking about cleanliness, aren't they?
Yeah, and I guess the danger is that sometimes you can over-pathologize normal experience. And I mean, we were even talking, we had some training recently, didn't we, about kind of the impact of social media on this kind of problem, and how, in TikTok, you get these videos of 5 signs you have OCD, or 5 signs, and people can watch these videos and identify with them and convince themselves that they have a disabling problem that they might not actually have. So that might be one side of it. But we would certainly advocate normalizing problems like these. And, as we were talking about earlier, OCD thrives in the dark. And actually getting it into the light and having it in as part of the conversation is a really good way of helping to support sufferers.
There's been a few questions sort of around this area of what's the most common age group, and sort of, is it more prevalent in certain age groups or certain sexes or certain races, for example?
I mean, so the age of onset is mid-adolescence. We know that it's around 14, 15 is age of onset.
The most common age of onset.
The most common, the most common age of onset. It's difficult to know, because there's often a long lag between onset and people going to services. So there is a study that shows age of onset ring around adolescence, and then 15 years later they were going to services. So it's sort of hard to know, I think, isn't it?
But equally, people could be into their 30s, 40s, later life, and suddenly develop it for different reasons as well. So, but most commonly, I think we would expect adolescents to early 20s, that to be the kind of the most vulnerable age to developing problems like this.
And culturally, it's across cultures.
Yes.
It can have different flavors, and so, for instance, I've seen changes in the themes that are like BSE. A lot of you are too young to know. BSE was a big one. AIDS, HIV was a big one. So the themes of it can follow what's happening in the media and what's happening in public sort of health. But it's cross-culturally the same prevalence, 1 to 2%.
What impact did lockdown have on the percentage of the population that have OCD, if we know that already anyway?
Well, this was really interesting from our point of view, because, I mean, try treating somebody with contamination OCD in a pandemic where there's a virus, and all of a sudden there's government guidance on hand washing, and so it really did exacerbate people who had it initially. And I think our task as clinicians was really helping somebody with OCD separate what the accepted guidance was from what their compulsions were telling them to go above and beyond doing. But we certainly did see more people initially coming forward with contamination fears based on COVID. The argument is, though, if the fear is real, it's not really an anxiety disorder, if there's an actual real threat to it. So I think the pandemic certainly created a vulnerability, and that's possibly more lasting now. This is anecdotal, because obviously there hasn't really been the the formal research conducted yet, but I've certainly had more conversations about germs and contamination in the years that have followed COVID. And I wouldn't be surprised if there has been a rise for that reason.
A few people have asked if OCD can be treated with medicine or if there's any sort of alternative treatments. If CBT, perhaps, I don't know if it would work on some people. Is there any sort of alternative treatments?
Yes, there are. Yeah, so NICE guidelines would suggest one of the SSRIs, serotonin
Reuptake inhibitors.
Yeah, which are the common antidepressants. So people might try, we might try without medication to start with, or if they are more severe, or if the talking therapy needs a boost, because sometimes people find if they're very low as well in mood, that they're less able and motivated to do some of the experiments and they need to do, that they might go sort of therapy alongside pharmacology might work better. So yes, that's SSRIs are the recommended.
We say that medication won't stop intrusive thoughts, and it might not even stop the meaning that you give the intrusive thoughts, but it might put a cap on how distressing the feelings you get can be. It might help to kind of bring the emotions experienced into a slightly more manageable bandwidth that can, as Claire was saying, facilitate treatments and different responses to those thoughts. So I think the evidence shows that the most potent effective treatment is a combination of antidepressant medication plus talking therapy at the same time.
Someone's asked this: do patients suffering of OCD realise that their obsessions are irrational, or do they believe that it's fairly normal?
That's a really good question. And diagnostically, they have to acknowledge that they're not based in reality, because if they did believe the intrusions, then we would label that as a delusion in a way. That's a different problem entirely. So that there is that kind of conflict that a person with OCD experiences. They'll have these powerful concerns that something terrible will happen, and I believe that this will happen if I think it. But at the same time, they'll be aware that this isn't rational, and that this is just a thought that I'm having. So it's that, yeah, there is insight. In order, diagnostically, there needs to be insight for it to be classified as OCD.
And it's like a superstition. So patients will often say to me, I know this is not logical, I know this can't happen, but it feels real. And so you know yourself, if there's a ladder that you don't want to walk under, you know nothing's probably going to happen. Or equally, the example that we use when we're training, when we get therapists to write down, I wish that so-and-so will die today or something. We all know it is not going to make it happen, but it feels real and horrible and slightly superstitious. So that's the same with OCD patients, probably, that they know it's not rational logically with their head, but not necessarily with their heart or their stomach.
And again, that's a product of the way that our brains are structured. You know, the higher areas that evolved later are not always compatible with those more primitive brain areas responsible for adrenaline and the amygdala and fear and all of that. So there's a neurological explanation as to why that's the case. But yeah, I guess our answer would be, for it to be classed as OCD, there does need to be some insight into the problem.
A great question.
Definitely.
Thanks again, Claire and Stephen, and everyone who's attended. We'll hopefully see you all next week. So thanks very much, and hope everyone has a lovely rest of the evening.